the patient that we can never promise total resolution, because you know how demanding they can become. We have scars of various morphologies, such as the ice pick, which is the vast majority of atrophic scars. These are narrow, they extend very deep to the deep dermis or subcutaneous tissue. Hence, these are not really amenable to laser resurfacing. We have also the boxcar scars with clearly demarcated edges. These may be shallow or they may be deep, and these can be improved with laser resurfacing. And of course, the rolling scars. These are typically wider, they have an undulating appearance, a shadowing appearance, and they have tethering. So in these cases, subcision to release the subdermal component can greatly improve the appearance of these scars. So what is our goal in the treatment of atrophic scars? We want to stimulate collagen and elastin within the depressed areas. And as we mentioned, since these are very difficult conditions to treat, one of the most difficult dermatological conditions to treat, combination treatments are indicated. A very recent consensus in 2022 looked at what recommendations for which type of scar. And they actually prioritize different lasers for different types of scars, subcision, in fact, transdermal delivery of drugs into the scar. But the general conclusion was that ablative fractional lasers are the first choice in atrophic acne scar treatment, and that combination treatments are often recommended. So the protocol that we've been adopting is, first, we use a fractional erbium YAG laser, which is tunable. It's tunable in depth, and as you will see later on, it's also tunable in terms of how much coagulation we can add to the erbium YAG laser. And then we also use, in the same session, polyl-lactic acid suspended in water. The PLLA is either injected prior to the resurfacing, especially in cases where we have rolling scars, so we can do some subcision and inject the PLLA, or we apply the PLLA immediately topically afterwards. So we know that ablative fractional lasers, what they do is literally they treat a fraction of the skin, and they leave a lot of intact skin with adnexal structures as a reservoir for rapid healing. So reepithelialization is relatively rapid. So we know that we have basically two wavelengths, which are very commonly used for ablative fractional resurfacing. We have the erbium YAG laser, which emits a wavelength of 2940, and the CO2 laser, which emits a wavelength of 10,200. So each of these wavelengths, these energies are well absorbed by water in the skin. The highest peak of absorption is the 2940. So what happens is that the water in the skin boils and it vaporizes, and with it comes off part of the skin. So it boils to about 100 degrees to remove epidermal and dermal layers. But we have also heat transmission in the vicinity of the treatment, and this ends up with giving us some coagulation and collagen remodeling due to heating of the tissue. And as we can see, the erbium has about 14.6 times the absorption of water versus the CO2. What it means is that with the erbium, we have much less thermal damage. Much less thermal damage hence translates into being safer for darker phototypes, phenotypes 4 and above, which is actually, I can say, the majority of our population. So what are the skin renewal mechanisms with this kind of ablative fractional laser? We're removing damaged tissue, and the thermal effect is good, of course, because we can also deposit new collagen and elastin. Mainly, the important thing is that we need to get to the depth of our lesion. We need to reach the depth of the scar. So we know that the atrophic acne scars are very deep in the deep reticular dermis. So we need to ensure that we reach this depth. And the erbium YAG laser has been shown time and again on histology to really improve skin quality. Here, for example, we have in this publication treatment after one session. We can see, for example, here where we have a poorly defined dermoepidermal junction, we have poorly organized collagen fibers and a lot of interfibrillary spaces. And this is 2 months after a single session. We have a very wavy dermoepidermal well-defined junction. We have organized collagen and much less interfibrillary spaces. So it's proven that the Erbium YAG laser is a powerful tool to remodel skin. So the Fractional Erbium YAG is the one that we use. Of course, again, it's being Erbium YAG, the target is water, but we can tune in specific depths. We can go 100 micron, 200 micron, 500, 800, up to 1,500 microns in depth. And as well, we can select the density, whatever density that we want. Another very important thing is that we can also tune in coagulation. So essentially, it's a cool laser. So for example, when you first hit the shot, high fluence, you have your ablative zone. Then you can target in coagulative fluences below the ablation threshold and progressively increase the coagulation zone each time. So in fact, it can translate ultimately, depending on the patient phototype, we can use it as a CO2 laser or we can use it as a YSGG laser, very powerful. So this is some histology showing you erbium alone, coag level 1, and look at the range of coagulation. Coag 2, progressively we're getting, and coag 3, more and more coagulation. Now, what is transepidermal delivery? What we have done, actually, we have created microperforations in the skin. So therefore, we can push either just by applying topically, which we have done in the past, just apply topically your product, whatever it is. In our case, it's PLLA. Or we use a special ultrasonic hammer to literally give a push-pull effect, remove the exudate in the skin, and push in the active compounds. So PLLA, why PLLA? PLLA is what we use is a suspension of 150 milligrams of these crystals in sterile water for injection. And when we put it into the skin, either by injection, as I mentioned, or topically, what happens, we elicit a reaction. We have a wound healing reaction. We have the leukocytes, monocytes, macrophages trying to come and remove the particles from where they are, but these particles are too large to be phagocytosed. Ultimately, you have the formation of foreign body giant cells, which again trying to mop up the PLLA. These release cytokines. The cytokines attract fibroblasts, and of course the fibroblasts start producing collagen and elastin. With time, the PLLA is broken down and eliminated, and all you are left with is the resident soft tissue. So we can see that on biopsy, the PLLA particles are still present at 12 months. By 30 months, so it takes literally around 30 months for the PLLA to be eliminated, which is one reason why in various studies, as this one here, we can see that type 1 collagen at 3 months are at a very high level after PLLA injections. This is a retroauricular injection study in volunteers where they took biopsies. And it was found that they have up to 66.5% type 1 collagen increase at 3 months, which is major because we know that type 1 collagen is what we want. It's associated with healthy skin. And type 1 collagen has a half-life of 15 years. So whatever we can do to induce type 1 collagen is to our advantage. Now, do these particles really penetrate these microperforations? And these are cadaver studies showing that they do penetrate into the dermis. And this is another one by Dr. Weibel's group, where they showed that the polarized light shows the particles of PLLA within the microperforations created by this time a CO2 laser. And these are her results with patients with atrophic scar. This is on the leg before and after one treatment. This is a tracheostomy scar before and after treatment. Therefore, we do have evidence that the PLLA can penetrate these perforations. So just some examples of combination where we've done both Erbium YAG, either as Erbium YAG alone, or in some cases we have tuned in coagulation with lighter phototypes. This is one session. This is before and after single session. Again, this is 2 sessions, single session, and this is our last case, single session, but we were very, very aggressive with her. We went down to 850 microns, 900 microns in some areas. The recovery was relatively slow, but after one session, I think the results are quite dramatic. We have just started now to measure scar depth, just as an example to show you. For example, we can look at each specific scar. We can see that the depth was 0.11, and then it's gone down by half. And this is only in a few months, and we know that the wound healing continues for several months, and the improvement will continue for several months. Side effects, especially if you're aggressive, there is not only pinpoint bleeding here, you can have quite profuse bleeding in some cases, especially with only erbium, a lot of edema, erythema, crusting. This is the patient. She had erythema for quite a long time. We did not do anything. We did not put her on any, she was a model, on any inhibitors of melanogenesis, or we didn't do any pulse light treatments, but easily you could follow up with inhibitors of pigmentation. You could follow up with IPL treatments or broadband light treatments. Because one of the things is the post-inflammatory hyperpigmentation we need to manage, and persistent erythema in some cases. So there's no doubt that this combination seems to be working for us of the fractional Erbium YAG laser and the poly-L lactic acid biostimulant. Thank you.